Not here. Then next is Bhakti Sukla. She will speak on use of steroids in ocular inflammation. Better safe than sorry.
So, my name is Dr. Bhakti. I am from Narayan Netralaya, Bangalore. I will be presenting on use of steroids in ocular inflammation. Better safe than sorry. So most of the times, many people feel that it's just uveitis and we can treat with steroids, topical, oral, and sometimes they go on to give even depot steroids. So I just wanted to discuss a few cases on this topic. My first patient is a 43-year-old female. She is a dentist working in United States. She was a known case of rheumatoid arthritis and had a history of necrotizing scleritis. And she had had a long history where she kept visiting multiple, premier institutes included. And her scleritis was not coming under control. At the time of presentation, she was on ATT and on steroids 40 milligrams oral. She had received a posterior subtenon injection. Previously, she was also treated with biologics including infliximab and adalimumab. She was referred to us by the rheumatologist to rule out secondary infection post-immunosuppression, as her MRI scan had showed some granulomatous lesions in the retina and choroid. So this is the old record that she was carrying with herself. So these were the peripheral ulcerative keratitis lesions in the right eye and the area of scleral melt. In the left eye, there was active scleritis and a nodular scleritis lesion in the inferotemporal quadrant. She also showed us images of when that melt had increased and she had undergone a scleral patch graft, which was followed by a posterior subtenon's injection, which only led to worsening with scleral melt of the graft and uveal show. Also, there is development of posterior subcapsular cataract, worsening her visual acuity. So at presentation, she had this picture where, as we can see, there is active scleritis in both the eyes. Fundus examination revealed a large supranasal choroidal detachment with pigmentary changes and a nodular posterior scleritis with some subretinal fluid around the lesion. Similarly, in the left eye, there was an active lesion with suspected choroidal granulomas as well, and there was a lot of fluid at the macula. She did undergo AC TAP previously also, which was negative for mycobacteria, eubacterial genomes, and panfungal genome. Her QTB was negative. Even though she was on ATT, her lesions kept increasing. So she was referred to a chest physician to rule out multi-drug-resistant tuberculosis, and he started her on levofloxacin. In view of accentuated immunosuppression, we also started her on voriconazole and valacyclovir to be on the safe side, and her immunosuppressive drug was changed to a Janus kinase inhibitor. She underwent a repeat patch graft in the right eye and received an intravitreal ranibizumab injection for the left eye to resolve the macula and improve her vision for the go. She returned to US and we could not have a long-term follow-up with her, and she was, multiple places she was going and taking her treatment. Nevertheless, she shared her images. And we could see that there was shrinkage of the lesions and her visual acuity was also improving. So basically from this case, I wanted to just highlight the point that it's always better to avoid depot steroid injections in patients with necrotizing scleritis and receiving multiple immunosuppressive treatment when they are prone to systemic infections. We may not be able to identify their markers, even serological markers may come down-regulated in them. My second case is a 59-year-old female patient. This is a case of actually a diabetic macular edema, and we can see these findings on OCT which suggest an inflammatory etiology of the macular edema, and hence in recent use they have also started giving intravitreal steroids for the macular edema. But 2 weeks later, this patient presented to us with acute retinal necrosis. We can see these the periarteritis lesions at the macula and also the large confluent whitish lesions suggestive of necrosis, and PCR came positive for VZV. These are the OCT findings where the macular edema is still there, and there is necrotic lesions with hyperreflectivity of all the layers in the periphery through the lesions. The patient gave history of chickenpox, and so this was a case of acute retinal necrosis secondary to VZV reactivation in the eye, and the patient was treated with a few doses of ganciclovir injection and followed up with valacyclovir. The lesions healed but with necrosed retina. So always check for a history of viral infections before giving depot injections to patients, and there is a risk of viral reactivation. So not every time that we will be able to know, but least that we can do is keep them on regular follow-up and advise that if you have floaters, redness, diminution of vision, do report as quickly as possible so that we can minimize the area affected. Next comes the Ozurdex, and Ozurdex itself is a very good treatment modality in many, many ways. There are some technical difficulties, and this is a picture of a fractured Ozurdex. Nevertheless, it worked. And the intralenticular Ozurdex, which is the biggest fear of any new person trying to give an Ozurdex injection. Okay, so with that, so I'll go to the 60-year-old male patient who had a history of traumatic retinal detachment with IOL subluxation. He underwent surgery, but with all this trauma and post-operative inflammation, he kept developing cystoid macular edema. He had received bevacizumab and IVT injections, but still he had persistent edema. So this time, we decided to go ahead with an Ozurdex injection. But the patient came back after 1 month with smoky vision and seeing a line moving in front of the eye, and it was actually that the Ozurdex had migrated into the anterior chamber. On initial examination, the optometrist who had seen the slit lamp had noted it as a hypopion. So, yeah, so this Ozurdex implant may mimic an hypopion. We need to do proper examination. And yes, the patient was being posted for surgery. We started the, the treatment of the corneal edema and the inflammation which was there, but before we could do the surgery, the implant had again, migrated back into the vitreous cavity, and there was no recurrence of anterior migration again. Nevertheless, it is always a learning that we need to be aware that this can happen and watch out. This is one patient with, this is a different patient actually. This is a patient with iris coloboma with an intraocular lens. And we need to also make sure.
How many more slides there, Dr. Sukla?
Pardon?
Your time is
okay,
off
so
a long
so
time,
dexamethasone implants, we need to be aware that we should avoid them in cases of posterior capsular openings, zonular dehiscence, aphakia, and iris coloboma. At least we can just remember these couple of points. And last case is a patient of topical steroid use. This patient was previously diagnosed with Posner-Schwarzman syndrome and again visited many places over the years where patient kept having recurrences of raised intraocular pressure. Treated with topical steroids, she would improve. But then at one point of time when she came to us, we decided to repeat the AC tap, which was still negative. But by use of confocal microscopy, which we do use in our center, we suspected etiology of virus, and we treated her with viral acyclovir. And here we can see that from initial stage, when we see her records, she had multiple recurrences of raised intraocular pressure, but just with clinical suspicion, if you can start the patient with antiviral therapy, you can reduce the recurrences of inflammation. Yeah. So just the take-home points that we should have cautious use of depot steroids in patients on immunosuppressive therapy, patients with past history of viral infections, patients with SFIOL, aphakia, zonular dehiscence, and iris coloboma. Also avoid them if you don't know what the exact etiology of inflammation is, and very high index of suspicion for viral etiology for recurrent hypertensive uveitis. Thank you.
Yeah. Thank you, Dr. Bhakti. One thing, actually, in some cases you gave intravitreal tricot and in some cases you gave intravitreal Ozurdex. How do you decide for that? To whom you will give tricot and triamcinolone acetate intravitreal, or to whom you will give Ozurdex implant?
Okay, so I think I would think of 3 conditions. Initially, the economic constraints in our population where even if I think the patient would need a Ozurdex but can't afford, then I would still go for an IVTA. IVTA is much shorter lasting than Ozurdex.
Yeah, that is more important is duration of action.
Yes,
then only comes the economic
So if I
part.
feel the patient is unilateral and will need a long-term immunosuppression, so Ozurdex will counsel. And also Ozurdex has lesser chance of raised intraocular pressure. So sometimes we take a clearance from the glaucoma and go ahead with Ozurdex rather than IVTA.
Okay. Okay. Any other questions for her? Anyone wants? No questions? Okay. Okay. Thank you, Dr. Bhakti.